Welcome, everybody. I'm Angie Sally Krupp. I'm the Chief Strategy and Development Officer at the Keck Medicine of USC Department of Surgery. I'm actually here today with our esteemed surgeons of the Division of Thoracic Surgery. We've got the Chief of the Division, Dr. Tony Kim, with us, along with Dr. Sean Whiteman, Dr. Elizabeth David, and Dr. Scott Atai. We're here today because we frequently get questions about COVID-19 and lung disease. So we've gathered the best group of people here in the department to help answer some of those questions. So what I'm going to do, guys, and I really want this to be as informal and conversational as we can make it, because we're all stand to learn something here. So I'm going to run through the questions here as they have been written and given to me. First, how does coronavirus affect the lungs?
Well, I think coronavirus affects the lungs in a variety of ways. And if you look at sort of the clinical presentation of it, it can range from the asymptomatic presentation all the way to a destroyed lung that can render the patient incapable of breathing on their own. And as such, the radiographic findings can mirror that too. You can have maybe just small infiltrates on the lungs all the way to a destroyed lung. So I don't know that there's a classic way per se. I think we're seeing a whole variety of presentations, and I think it's largely owed to the fact that it's affecting people differently along the way.
Yeah, I think that the fact that the disease is novel to humans here relatively recently, we're still kind of learning what its actual effect is. We know that in patients who have succumbed to the disease, it is a fairly severe injury to the lung itself, with some features that aren't seen in other types of infections. As an example, small blood clots that seem to be forming inside of the lungs, which are preventing blood flow to those aspects of the lungs and not allowing oxygen or gas to get to where it needs to be, and also leading to severe injury to those areas where they don't receive enough blood flow, and then that part of the lung can't survive, which might account for why the recovery for these individuals affected can be fairly prolonged.
So that being said, would somebody that has had either lung or esophageal cancer, are they at a higher risk to get COVID, and what does their recovery maybe look like?
So I think patients with lung or esophageal cancers often have many of the predisposing risk factors that set patients up for poorer outcomes with COVID-19. And so some of those disease processes or medical problems would be having a history of smoking, having COPD, having high blood pressure, having congestive heart failure. All of those diseases can be associated with lung and esophageal cancer. And then again, it also sets the patients up for more severe outcomes if they were to acquire COVID-19. But that being said, a cancer diagnosis during the time of this pandemic, it's very important to take that seriously and to continue to seek medical care. I think we're going to talk about some of the novel ways we're taking care of patients right now, but it is crucial that a cancer diagnosis not be ignored right now, because the death rates from cancers are still higher than the death rates from COVID-19.
Are there any particular things that we're doing here at Keck Medicine to keep those patients safe?
So I think that we're doing the best we can to keep COVID patients very separate from non-COVID patients, in terms of isolating the patients themselves, in terms of having separate teams care for those patients. So there's very little overlap between the caregivers and the patients, really trying to keep the two populations very, very separate.
Right. I just wanted to add on to that point, which is, the CDC is predicting there's going to be a cancer fallout from this sort of the COVID patients, rightly so to some degree, gaining greater attention in this time period. And so the cancer patients some of them nationwide might fall off the grid, so to speak. But I think one thing for us in our group philosophically is that we recognize that cancer is just as important and as lethal of a disease as COVID, to Dr. David's point. And so we philosophically took it as a priority that we wanted to still make sure that our patients got the appropriate cancer care during this time.
So that actually brings me to another question here, and that a lot of people have been asking, they come on campus and they see everybody wearing a green sticker. What does that represent to people? You've got your stickers on. That's good.
So that represents that we've been screened. So we are screened every day. We walk in the door, we sanitize our hands, we put a face mask on, we get our temperature checked, and we get our sticker. And we're asked a series of questions about whether or not we have any symptoms or if we've been exposed knowingly to anyone with COVID. And right now, that is the best we can do to protect our workforce and our patients.
And
for the record, we're behind closed doors. That's why we're not wearing face masks right now.
Yes.
I was just going to say that's the reason we don't wear them right now. I also know, just from my role, looking at surgery as an entire department, is the way that we're scheduling appointments is different. We're spreading people out. So there's not a bunch of people in the waiting room. And I know that we're being really thoughtful about those things as well. So if you're a patient coming here for care, this is one of the safer places that you could probably be right now. Okay, back to my FAQs here. How do you operate on COVID patients?
Sure. So, so the answer, I guess, is yes and no. I'll start with the no. So for patients who are diagnosed with COVID or actively infected with COVID, we are not performing elective operations on them. Elective being we are not operating on them for a cancer, for example. We are not operating on them for who need a knee replacement or something along those lines. So for someone who has active COVID, who's currently infected, we are not performing elective surgery on them. On the other side of the coin, the yes is there are patients who have COVID-19 who have diseases that require urgent or emergent intervention or require treatment in the context of COVID. As an example of one of the more common procedures in this setting is a tracheostomy or a placement of a breathing tube into the neck. Those procedures are still done on COVID patients. Drainage procedures in the chest, those are still done on COVID patients. So if someone is actively infected and requires intervention, it will be performed in the appropriate manner. And to address maybe a little bit back to the prior question, Keck has arranged operating rooms that are COVID only. So we have isolated rooms, isolated teams, so that if we do have to perform surgery on patients who are actively infected, they are completely isolated away from non-COVID patients who may be coming in electively. They never really cross paths, so to speak.
So, Dr. David, I want to come back to something that you said, and it's one of the questions that we get frequently, just about people not ignoring their health and actually seeking care. Telemedicine, what can any one of you tell me about how that works? Do surgeons do telemedicine? It's not something that I would automatically assume if I need to see a surgeon that I would talk to them over the video like this. What can you guys tell us about how it works, and do people like it? How often do you offer it? Anything that might give somebody an understanding of that, what telehealth is.
Surgeons definitely can do appointments via telemedicine, and we definitely do here regularly, and especially during this era of COVID-19. We've been doing a majority of our visits over telemedicine, and as a division, actually, we were doing telemedicine before COVID-19 because many of our patients have a distance to travel, and we're trying to accommodate to that. But just like all telemedicine appointments for a surgeon, the physical exam component is a little more limited over video, but we still can accomplish a lot and get to know show the patient and explain the imaging and talk about operations. But if an operation is needed eventually, we do want to meet the patient. And so at some point we'll want an in-person visit, be at additional time or the morning of surgery. Even once COVID-19 is improved in our community, we still want to continue to offer telemedicine just for the convenience, because some patients need that, especially if they have a distance to travel.
Yeah, absolutely.
I think one of the probably biggest advantages I've noticed is a lot of our patients are older and have adult children. And using telemedicine, we've actually been able to incorporate a lot more family members into the visits, which has enabled some of those adult children to participate and, directly hear what we're saying, hear the surgical discussion, see the pictures from the CAT scans. And I think it helps their parents with their medical decision making. So it's a real enhancement, I think, to our practice.
That's an incredible benefit. I mean, I think that's one that people don't automatically think of, but I'm glad you brought that up.